When you think about big systemic challenges, well, few feel as complex, as deeply personal, really, as healthcare policy.
Absolutely. It touches everyone.
We're talking about everything, from developing new treatments to just getting people to embrace healthier lifestyles.
And that's a huge spectrum.
It's a field that's just riddled with subtle complexities. And getting new policies right, implementing them effectively and truly understanding if they're making a real difference. Gosh, it's incredibly difficult.
It really is. There are so many moving parts.
And we often make a critical error, don't we? We
Mhm.
sort of assume everyone involved sees the world through the same logical lens.
That's a common trap. But the reality, especially in health, is just far more nuanced.
Yeah. Our sources today, they reveal a core problem. Policies frequently stumble. And it's not because of a lack of funding necessarily or resources.
Which is often the first place people look.
Exactly. But it's because of the deeply held attitudes and, well, the behaviors of the very people they're designed to impact.
The human element.
Precisely. So this deep dive is all about a particularly powerful and I think insightful approach called Q methodology.
Mm-hmm.
It's a way to systematically map out these diverse viewpoints. It offers you, the listener, a shortcut, almost like having X-ray vision, into understanding the human context you're working with.
A way to see the different perspectives clearly.
Okay, let's unpack this then. Why is navigating healthcare policy such a complex landscape? We're talking everything from prioritizing clinical research to encouraging patients, manage chronic conditions.
It's vast.
And the research we're looking at really underscores that developing and prioritizing these clinical topics is incredibly hard in an environment of competing, often conflicting interests.
Oh, definitely. Stakeholders often have very different priorities.
It's not just about the science, is it? Or the clinical guidelines. It's profoundly about people, their values, their lived experiences.
It's true. And a key revelation here from the research is that the main stumbling blocks often aren't the basic resources, which, as you said, is what we might instinctively point to.
Right.
Instead, it's consistently the attitudes and the associated behaviors of key interested parties.
Ah.
And this includes those responsible for delivering the policy, like healthcare professionals,
Right.
and also those whose cooperation is absolutely required for its success, patients, the public, other stakeholders.
Makes sense.
So broadening this out, successful policy fundamentally requires knowing the context. It requires understanding how a given policy will fit with those deeply held stakeholder values.
So alignment is key.
Exactly. You can have the most meticulously crafted policy on paper, truly. But if the people on the ground don't connect with its purpose, or maybe if it clashes with their inherent values, it's effectively, well, dead in the water.
Dead on arrival. Wow. Okay, so if these invisible walls of differing attitudes are such major hurdles, how do we get past them?
That's the million-dollar question, isn't it?
The research we're looking at highlights Q methodology as a particularly powerful tool for this exact problem. Now, it sounds a bit mysterious, combining qualitative and quantitative research.
It bridges that gap.
What makes it stand out? How does it help us truly understand these, complex viewpoints?
Well, that's a crucial question. How do you capture not just what people think, but maybe more importantly, how they think? What makes their perspective unique and coherent?
Right, the underlying structure.
Exactly. Q methodology doesn't just measure opinions like a broad survey might. Its specific design, its purpose, is to identify groups of people who are like-minded in their viewpoint on a particular topic.
Like-minded groups.
Okay. Think of it like this. Instead of measuring individual traits across lots of people, it uses statistical techniques, factor analysis mainly, to find clusters of people who sort their ideas in remarkably similar ways.
Sorting ideas.
Yes, sorting statements about a topic.
Oh.
It effectively groups individuals by their shared perspectives, how they structure their understanding.
Okay.
And this process, it illuminates both divergence and convergence. It shows you exactly where there's consensus across different groups and where significant disagreement lies.
So you see the whole picture.
It's like mapping the entire landscape of opinions, clearly showing the sort of mountains and valleys of different perspectives rather than just taking a head count of people on one side or another.
Okay, that really clarifies the core idea. So we understand what Q methodology aims to do. But practically, how does someone actually conduct a Q study? What's the very first step in putting this approach into practice?
Right, the nuts and bolts. It begins with developing what's called the Q set.
Chew that. Got it.
These are a set of predefined statements, usually somewhere between 40 and 80 of them, and they need to be carefully chosen to broadly represent the entire universe of opinions you might find on that given topic.
Where did these statements come from?
Good question. They're drawn from existing research, maybe policy documents, but often, and this is critical, from in-depth interviews or focus groups with the target audience themselves.
So it's grounded in their reality.
Precisely. That ensures you're capturing the actual language and concerns of the people you want to understand. You're not just imposing ideas.
And who participates in these studies? Are we talking about large groups, like in traditional surveys? Thousands of people.
Not at all. That's actually one of its distinguishing features. Participants are strategically sampled and you don't need large numbers.
Really? How many then?
Typically, around 40 to 60 participants are considered quite sufficient. Sometimes even fewer can work, depending on the research question.
That's surprising.
Well, the goal isn't statistical generalization to a vast population, like saying X% think this. It's to ensure that all the potential viewpoints out there are represented in your study.
I see. Depth over breadth, in a way.
Exactly. So you're looking for a rich diversity of perspectives within your sample. For instance, if you're studying a healthcare policy, you'd want patients, healthcare workers, maybe admin staff, managers.
People with different stakes.
Right. Chosen specifically for their interest or perhaps their known views on the subject. You want the full range.
Okay, so once you have these carefully selected statements, the Q set and your specific group of participants, how do they actually interact with this Q set? What's the unique process for them?
That's where the Q sort comes in. It's the core data collection activity.
The Q sort.
Participants are asked to rank these statements, but not just individually, like agree, disagree. They rank them in comparison with all the other items.
How does that work, like on a scale?
They typically sort them physically, or nowadays often digitally, onto a grid. And this grid forces them to create a kind of quasi-normal distribution.
Quasi-normal, meaning?
Meaning they can only place a few statements at the absolute extremes, like most agree or most disagree, and the majority of statements have to fall somewhere in the middle, more neutral positions.
Ah, so it forces choices. You can't just agree strongly with everything.
Exactly. It's not just a methodological step. It's a critical design choice that reveals the salience of different ideas for a person. It shows us what genuinely rises to the top or sinks to the bottom of their priorities.
It offers far more depth than just ticking boxes.
Much more. It really forces careful consideration of the relative importance of each idea within their overall view.
Okay, that makes sense. What happens next?
And here's where the crucial qualitative layer is often added. After the Q-sort itself, there's typically a post-sort interview.
Talking it through.
Yes. And this isn't a quick survey asking, what did you think? It's a deep dive into why the participant placed certain statements at the extremes, the most agree or most disagree ends, or even why they left others in that neutral position.
Understanding the reasoning behind the ranking.
Absolutely crucial. This qualitative data gives context and meaning. It helps interpret the quantitative patterns that emerge later. It paints the full picture, behind the numbers.
Right. So you have the sort, you have the interview, then what?
Then comes the data analysis. Specialized Q method software takes all those individual Q sorts, each person's unique ranking pattern, and basically compares them all to each other.
Looking for similarities.
Exactly. It groups participants based on their sorting patterns. Imagine a room full of people. Q methodology mathematically finds those whose way of organizing their thoughts on this topic is remarkably similar.
Right.
These statistically similar Q sorts are clustered together, forming what we call factors. And these factors represent the shared viewpoints that exist within that group.
So the factors are the viewpoints.
Essentially, yes. The final output isn't just numbers or statistical categories, though. It's a rich narrative description of each viewpoint, each factor.
A story for each perspective.
Precisely. This narrative is built from a deep analysis of the patterns of the items, especially those statements that really define one viewpoint and distinguish it from another. It also highlights statements where there's broad consensus agreement across all viewpoints or strong disagreement.
That sounds incredibly useful for understanding the landscape.
It really is. It's truly about understanding the full story behind the data, giving policymakers a concrete, nuanced picture of the different ways people understand an issue.
That's a very clear breakdown of the process. Thank you.
Yeah.
Now, let's try to bring this to life with a real-world example from our source material.
Okay.
There was a UK policy, ran from about 2006 to 2013, that incentivized GPs, doctors to screen for depression in patients who also had chronic physical illnesses like diabetes or heart disease.
Yeah.
What's known as comorbid depression.
Yes, a common issue.
Right. But surprisingly, the policy was actually withdrawn because it simply didn't achieve its desired response. It didn't work as hoped.
Oh.
So what went wrong? And how did Q methodology help unravel this policy puzzle?
Yeah, this is a perfect illustration of Q methodology's power to reveal those hidden dynamics, the things you might not guess up front.
So what did they do?
A study was conducted using this method. They recruited 31 participants who actually had comorbid depression, so living with both depression and a chronic physical illness.
Target group.
Exactly. And these participants Q sorted a set of 57 statements specifically about their experience about living with both conditions.
Okay, and what emerged?
What particularly stood out in this study was the revelation of 5 statistically distinct viewpoints on depression among these patients. 5 different ways of seeing their situation.
5 distinct perspectives.
Oh, wow. And a key consensus finding was especially insightful. There was one statement: "The best thing for my depression is to see a health professional."
You'd think that would rank highly.
You might assume so, but it was ranked as neutral right in the middle across all 5 viewpoints.
Neutral. By everyone.
By everyone, statistically speaking. This suggested that participants either didn't have strong feelings about the benefit of health professionals specifically for their depression, or perhaps they felt quite ambivalent about it. It wasn't a priority for them in managing their mental health.
That's a major finding for a policy encouraging screening by professionals.
Huge. Furthermore, the study also identified some viewpoints where participants genuinely saw no link between their depression and their physical health conditions.
They saw them as separate problems.
Completely separate issues. For those individuals, their physical illness was one thing, their depression another.
Okay, so connecting this back to the policy.
This really underscores a wider point. These insights explained why that incentive scheme didn't work as hoped. Some patients fundamentally didn't understand the policy's purpose, why screen for depression alongside diabetes. Or they simply didn't see the value in what was being offered, especially if they didn't connect their physical and mental health in the way the policy assumed they would.
The policy's logic didn't match their reality.
Precisely. The findings suggested a critical need for a more flexible, maybe a more personalized approach to identifying and addressing depression in these patients, rather than a broad, one-size-fits-all policy that just assumed a universal understanding or acceptance of the link.
It sounds like it shifted the focus.
It did. It shifted the focus from a top-down mandate, assuming everyone sees the connection, to needing to understand the patient's individual reality first.
That depression example powerfully highlights how crucial understanding these nuanced viewpoints is. It's so clear that a policy based on assumptions about how people should think, well, it can easily fall flat.
It really can. The best intentions aren't enough.
But Q methodology isn't just for individual patient attitudes, is it? This methodology, as our source explains, can address even broader policy challenges.
That's right. It's quite versatile.
Let's start with the first challenge it tackles.
Yeah.
Deciding where to focus limited resources. Making those really difficult trade-offs in healthcare commissioning.
Yes, the priority setting problem. This raises an important question, doesn't it? How do you reconcile deeply differing, often competing priorities among all the stakeholders, patients, clinicians, managers, funders, when you're commissioning healthcare services or allocating finite resources?
Seems almost impossible sometimes.
Well, Q methodology can significantly help policymakers clarify these healthcare priorities. It does this by reducing the complexity of maybe multiple, sometimes overwhelming opinions into a manageable number of shared viewpoints.
So it simplifies the landscape.
It simplifies without losing the nuance. It clearly shows both where there's consensus and where there's disagreement. And crucially, it can even highlight the intensity of preferences around different options.
How strongly people feel.
Exactly. And potentially the opportunity costs associated with different healthcare policy decisions, especially if you frame the Q-sort instructions to reflect specific policy choices or trade-offs.
That sounds really practical. Are there examples outside healthcare?
Oh, yes. The source gives several compelling examples outside of healthcare, too, which really demonstrates its versatility in complex stakeholder situations.
Like what?
For instance, it's been used to help resolve conflicts around controversial airport expansion, like in Amsterdam Schiphol, where economic growth arguments had to be balanced against local environmental concerns and residents' quality of life.
Huge conflicts there.
Massive. It's also tackled complex issues in environmental waste management and even things like large carnivore conservation priorities,
Mm.
wolves, bears, where you have deeply held but very different values clashing.
Wow. Okay.
And bringing it back closer to health systems, in a U.S. hospital, Q methodology helped find consensus on strategic planning. They had competing views from hospital management, the board of directors, the medical staff.
Usual suspects.
Right. And the Q study provided a list of priority objectives that everyone could genuinely agree on. It even helped justify stopping several programs because the data showed a shared understanding that they weren't the core priorities anymore.
So it builds common ground.
It helps redefine problems with greater traction, moving beyond those polarized, maybe dug-in viewpoints to uncover a fuller range of alternatives and shared priorities.
Okay, so if Q methodology helps us understand where to focus our efforts, what about the next big hurdle? Actually implementing a policy successfully once a decision has been made. How does Q methodology assist there?
Absolutely. Implementation is key. The source provides another powerful example here, this time with antenatal screening policy.
Okay, pregnancy screening.
Yes. Now, the policy often states or assumes that women should be able to make an informed choice without bias from healthcare professionals when deciding whether to take up screening tests.
Sounds reasonable. Choice is good.
On the surface, yes. However, a Q methodology study found that women interpreted this idea of informed choice in vastly different ways.
Ah, not a single definition.
Not at all. And this directly challenged the policy's underlying assumption that all women want to make these decisions about screening without any advice or recommendation from healthcare professionals.
Some women wanted advice.
Exactly. Some women, particularly the study found, those from certain minority ethnic groups, actually wanted health professionals to give guidance and make recommendations. They saw it as a sign of care, of expertise, not as bias.
That's a fundamental challenge to the policy's premise.
It really is. And these findings had huge implications for the role of health professionals in providing information and supporting genuinely informed decision-making.
How so?
Well, it highlighted a critical need to improve the quality of care and ensure equity of access. It suggested reframing policy and practice guidelines with more, perhaps, relational approaches to autonomy rather than strictly individualistic ones.
Recognizing different needs and preferences.
Precisely. It helps policymakers understand that informed choice isn't some universally interpreted concept. It means different things to different people.
Fascinating. Okay, what about the third challenge mentioned? Evaluating if a policy is actually translating into practice and delivering the intended benefits.
Right, the evaluation piece. Our study on depression case finding, the one we discussed earlier with the withdrawn policy.
Yes.
That's a prime example of how Q methodology can help explain why a policy initiative may or may not have been successfully implemented. It got underneath the what to the why.
It diagnosed the failure.
In a sense, yes. Another piece of research mentioned involved people with diabetes. It showed that a lack of adherence to recommended diabetic lifestyle modifications diet, exercise, could be explained by a significant mismatch.
A mismatch between what?
Between the patient's understanding of their illness and their approach to self-management of their health and lifestyle.
How they saw their condition versus how the policy saw it.
Exactly. For example, some patients were reluctant to change their lifestyle because they had a perceived lack of control over their future health anyway. They felt fatalistic, perhaps.
So the standard advice just wouldn't land.
It wouldn't resonate. This study strongly suggests that clinical practices tailored to patients' actual beliefs and perspectives are far more likely to be effective than a generic, one-size-fits-all approach.
Personalization again.
It really drives home why understanding these subjective issues, people's beliefs, their viewpoints, is key to forecasting engagement and adopting policies more effectively. Especially, perhaps, for harder-to-reach groups whose perspectives might differ significantly from the norm assumed by policymakers.
So Q methodology sounds incredibly insightful, really broadly applicable. But, no tool is perfect.
That's very true.
What should we as listeners be aware of when considering this methodology? What are its inherent limitations, maybe future considerations?
Right. It's important to be clear about what it does and doesn't do. While Q methodology is excellent, as we've said, for identifying a range of views and clarifying their components, their structure,
Yes.
it isn't designed to tell you the prevalence of those views in a large population. It won't tell you, say, that 30% of people hold viewpoint A.
Ah, okay, so it identifies the viewpoints, but not how many people hold each one.
Exactly. Or it doesn't easily link them to broad socio-demographic characteristics like age or income in a statistically representative way. If you need to know what percentage of the population holds a certain view, you would typically need additional survey research.
How would you do that? Link the Q findings to a survey.
One method involves developing what are sometimes called Q blocks. These are essentially concise summaries, almost like mini personas, of the distinct viewpoints Q methodology uncovers.
Distilling each viewpoint.
Yes. They capture the core beliefs and priorities of each identified factor, maybe in just a few sentences. These Q blocks can then be built into a more traditional questionnaire.
And use in a larger survey.
Right, to estimate the prevalence of each viewpoint in the wider population. However, it's also really important to remember that policy-making decisions shouldn't necessarily exclude a viewpoint just because it turns out to be uncommon.
Good point. Minority views can still be crucial.
Especially if that viewpoint is characteristic of an influential group, maybe key professionals or a particularly vulnerable population. Numbers aren't everything in policy.
True. Any other limitations or considerations?
Well, another important consideration is the practical integration of Q methodology findings. While it clearly helps us understand viewpoints so deeply,
Yes.
there's actually less published evidence on how its outputs have actually been explicitly used downstream to plan or implement policy more effectively in practice. We know it can inform, but the evidence trail for how it changed decisions isn't always well documented.
So a gap between the research output and the policy action.
Potentially, yes. Or at least a gap in documenting that link. This suggests a crucial area for future development. Maybe a need for better ways to translate and present these rich, sometimes complex findings so they are readily accessible and, crucially, actionable for busy policymakers and practitioners.
Making the insights easy to use.
Exactly. Also, just practically, while it's incredibly powerful, conducting a full Q methodology study involves careful, qualitative work upfront, generating statements, interviewing, and then the specific sorting and analysis. It can be more time and resource intensive than, say, a quick online survey.
More upfront investment.
Yes, but the depth of insight it offers often justifies that investment. It provides a way to identify those tricky, subjective issues that often limit the impact of research findings elsewhere, and to truly understand important viewpoints that common, less nuanced methods might completely miss.
So, summing this all up then, what does this really mean for us, this deep dive into Q methodology? It truly shows us that getting policy right, especially in complex fields like healthcare, well, it isn't just about the hard data, is it? Or scientific decrees or top-down mandates.
Much more than that.
It seems fundamentally about understanding people, their beliefs, their values, their unique perspectives. It's about moving beyond simply measuring opinions to truly grasping the structure of how people think about an issue.
Exactly. You've hit the nail on the head. Q methodology helps us move beyond those often polarized black and white debates
How so?
by uncovering not just common ground, which is valuable, but also a fuller range of alternatives, different ways of seeing the problem that might otherwise be overlooked in a shouting match.
Seeing the shades of gray.
And the different colors, too. It equips decision makers with a nuanced map of the viewpoints out there. This allows them to anticipate potential barriers before they become serious roadblocks, to leverage opportunities that might resonate with specific groups, and ultimately to craft policies that are more likely to be accepted and truly implemented.
Why? Because they resonate more deeply.
Because they resonate more deeply with those they aim to serve. It ensures that policy considers the actual real-world reality of the stakeholders involved, not just an idealized version.
So for you, the listener, think about a time you saw a policy or maybe an initiative fail, whether it was in your workplace, your community, maybe even on a national scale.
We've all seen them.
Could it have been saved or perhaps been more effective if the decision makers involved had had a deeper, more systematic understanding of all the different perspectives involved before they launched it?
It's a powerful question to ask.
How might you use this idea yourself? This concept of mapping viewpoints to navigate challenges in your own work or your community? It really makes you rethink how we approach problem solving, doesn't it?